Good afternoon, everybody, and welcome to the Adult and Health and Social Care Scrutiny Panel meeting on Thursday, 10th of December. This meeting will be webcast live and will be available to view on the Council's website after the meeting. If I could request panel members to introduce themselves. I'm Councillor Haridan Zaman for Backley and I'm the chair of the panel. Peter.
Good afternoon, I'm Peter Bradshaw. I'm a co-optee to the panel.
David.
Yes, I'm Dave Rigby and I'm another co-optee on the panel.
Leslie.
Yeah, I'm Leslie Warner. I'm a councillor for Colne Valley.
Alison.
Hello, I'm Councillor Munro and I'm a councillor for Almondbury Ward.
Lynn Keedy.
Good afternoon, everyone. I'm Lynn Keedy and I'm also a co-optee on the panel.
Okay, and we also have Councillor Liz Smade, who's the chair of Overview and Scrutiny meeting as well. We have apologies from Councillor Vivian Louise Hamilton. Is there any other apologies?
None noted, none received, Chair.
Okay, thank you. If we can go through the minutes of the previous meeting. Are they a true record? Do we have somebody seconding, proposing that and seconding that?
Yes, I think accurate. Thank you.
Thank you. Somebody to second.
Yep. Accurate, yeah.
Okay. Item 2, if there's any interest that anybody wishes to disclose, you can do that now.
Yes, it's Dave Rigby. I'm an ordinary member of Swift.
Okay.
And yes, Leslie Warner. I'm one of the governors of the trust, the Calder and Huddersfield Foundation Trust.
Thank you. Lynn?
I need to declare two interests this afternoon, please. The first one is that I'm a volunteer with South West Yorkshire Partnership NHS Foundation Trust, based at the Calderdale and Kirklees Recovery and Wellbeing College. And also I am a volunteer with Health Watch Calderdale and Kirklees.
Thank you. Jenny, did you want to come in?
I wanted to indicate that Lynn wanted to speak. It's all right, Chair.
Thank you. Okay, well, today's meeting is being held in public and it is being live webcast. Item number 4, we have no petitions and demonstrations for this meeting. Item 5, public question time. We have no questions from the public at this meeting. And if we can move on to item 6, the impact of COVID-19 on mental health services. And if I can ask Chris to give us a brief overview of the report. Chris,
hello everybody. I've accompanied today by my colleagues and as arranged with Richard, we would advise that you'd already would have seen the presentation and that you would prefer us to talk about issues that you wanted to raise rather than go through it. So we're happy to do that. Obviously, we
summary just to, because we're on webcast and for members of the public, just give it very quick.
Well, obviously the information that we provided looked at the operational challenges that we had from March 20 at the commencement of the pandemic or the national pandemic, and covered our early response in setting up our gold, silver and bronze command structures. It talked about how we maintain continuity of services and how we developed cohorting procedures for our inpatient units. We then went on to talk about the ongoing resource challenges that we'd had in terms of staff absence and our priority around keeping our staff well-being at the forefront and keeping people well, and obviously meeting the needs of service users. We then went on to talk about our recovery and how we were adapting the use of how we could deliver services and how in particular we were using technology. You then asked us to talk about the demand for our
Ask the members to put your mics on mute unless you're speaking, please, because we are getting a lot of background noise.
So we then went on to talk about the demand for our services. You asked us to look at our core and enhanced teams and how the demand had fluctuated during the period, and we provided information about that. We talked about our approach to how we dealt with outbreaks on the wards, again in relation to specific queries around how we had established our standard operating procedure, and we gave some information in particular about how we'd managed some outbreaks in Halifax. And again, we have got colleagues on the call today who dealt with that firsthand, who can answer any questions and give some more detail. We then went on to talk about caseloads of the core and enhanced team, again, a specific request of the panel, and about how we'd balance the contact methods between face-to-face, telemedicine, and then telephone contacts. You then asked us to go on about to tell you about the Recovery College activity during this time, and we were able to talk about the developments there and how we'd maintained links and developed virtual offers to reach out to members in the community, and how we'd work with Creative Minds and other community and voluntary sector providers to meet people's needs. We then went on to talk about our carers passport, which has been launched for both unpaid carers and staff, carers for the family, and that was launched at the end of November. And then just about how we'd partnered with all sectors in terms of local recovery for Kirklees, that we'd managed to maintain our services throughout this period to people in need of crisis care, and we've based our price during this time. And just how we're balancing at the moment our recovery plans in line with national requirements with dealing with the very challenging situations that COVID's presenting to health and social care at the moment. So that was our overview. We have got Becky Smith, who's an advanced clinical practitioner who has actually dealt with COVID outbreaks on wards and can speak to that. We've got Sue Sutcliffe, who's General Manager for the Enhanced Pathway in other areas of the community, who can answer detailed questions about how we've worked safely with people in the community. And we've got Melissa Harvey, who's General Manager in Community and Recovery, who can speak to a range of issues, not least the Recovery College and how our core pathway works. So we're happy to take any questions and have any discussion that the panel wants to take us to. Thank you.
Thank you, Chris. If I can put it to the panel to start asking questions. Peter, do you want to go first? We can't hear you, Peter. You're on mute.
Sorry, apologies. I just wondered, please, a general question, Chris, about overall trends in incidents, referrals in the first instance. Have you noticed any difference in the volume of referrals during the pandemic?
I think I'll ask Sue as General Manager in Community to answer that, because I know we have done a lot of work about how, I mean, some of the slides speak to that as well, Peter, but Sue can perhaps give you an idea of what it's been like in the teams and how we've dealt with the demands from service users wanting to be referred, etc.
Yeah, thanks, Chris. Thank you, Peter. Yeah, I manage the enhanced teams, and for those of you that are not aware, the enhanced teams are teams that manage people with the most complex of mental health needs. But however, I think the trends that I'm going to talk about, I think are probably relevant for all of the teams in that. From a referrals perspective, there was quite a marked drop in referrals round about March, April time, and that can be seen on one of the graphs that's included in the slide pack. and that was sustained for about 2-3 months, and then we slowly started to see a rise in referrals, and to the point at times where the referrals were higher than perhaps the sort of previous year. So we are very. It's very clear that there was a suppressed demand round about that time.
In fact, there were deferrals, not. It's not that you didn't get referrals; they were deferred.
Well, unknowingly, yes, it wasn't something that we managed, and I think there's a number of reasons for that. And you the second part of your question was about trends, and I think this is obviously it's the trends that we've gone on to understand that have clearly impacted on the referrals. So for example, early on, round about March, April time, we noticed that people with a psychotic type of presentation were people that were more likely to have a deterioration in their mental state, and we did have to manage some very difficult clinical crises as a result of that. At that same time, what we noticed was that people with a non-psychotic presentation, mainly people with a personality disorder presentation, the referrals and the contacts from that cohort of service users reduced. That's levelled off more since, and I think we've got a presentation now that's more like the sort of the steady state, the usual flow, with one exception really, and that's our early intervention team. So that's early intervention in psychosis. So those are teams that work with people who have got an emerging psychosis, and that starts at age 14. Normally the age range is 14 to sort of 35, and initially the teams were the service spec covered that, but we've noticed since COVID that there's an increase in referrals of people with a first episode psychosis of the higher age range of the adult spectrum. So a significant number in comparison to previous in their 50s, for example. And I think there's a number of reasons why that might be the case, but that clearly.
Are these predominantly paranoid people, or is this an affective thing?
Well, it's people with an emerging psychosis, so it will
an affective psychosis or a schizoid-related psychosis.
I think possibly more ineffective, yes. and I think it's in response to a number of changing environmental factors, that they're finding it really difficult to process.
Yes, losing your job and.
Absolutely, not having your normal support system around you, and that's clearly been a key part of people relapsing. The fact that they haven't got family and friends visiting them to give support, but also they haven't got family and friends that would normally alert us if there was a concerning presentation or deterioration.
Right. Just one last little point, and then sorry, I'll let this go, because I was interested in throughput and discharges and the rest, but we can leave that. I just wondered how significant telemedicine had been in the diagnosis of these acute people. I'm thinking about particularly the acute young psychotics that you're talking about, the people who would present in lay terms as a bit of a danger to themselves or a bit of a danger to others, or would look that way even if they weren't. I wonder how telemedicine had figured in that, please.
Probably not as helpful as with other types of presentations, and what we learnt, the presentation talks about a RAG rating that we applied with service users to determine who we would prioritise having face-to-face contacts at a time when things were very sort of unsteady, and we actually, because of the risk factors, we actually made the decision that people with a psychotic presentation, we would be better off having face-to-face contacts to be able to do a full assessment of how they were, because quite often people disengage with us when they're at a psychotic point. So it's very, very difficult. The tele care type of approach requires service users to really want to engage with us and engage with that consistency.
That's reassuring. It's reassuring. Thank you very much.
You're welcome.
Thank you for that. Dave, do you want to ask your question?
Yes, I've just got a comment first. I thought the section on the recovery college was very positive. It was good to read about all that. My question's on the page which deals with the contact method for the two teams. And I just wondered whether there'd been any feedback from service users in terms of contact by phone or the use of telemedicine, any feedback about what people felt about those methods. And I just wondered in terms of the change in the way in which contact has been made, whether that's had any effect on response times to initial inquiries. Thank you.
Thank you. Melissa, do you want to talk about, are you okay to speak to this?
Yes, of course.
Thank you, because I know we have also been involved in some digital inclusion work as well, which I think is important to mention. So thanks, Melissa.
Absolutely. I think it's fair to say that different groups or different cohorts of service users have different experiences with telephone contacts. So as Sue was talking about, or telemedicine or digital ways of delivery of therapy and intervention, as Sue was talking about earlier, we learned very early on that there are people or groups of people within our services who actually digital provision doesn't work for them. It isn't an appropriate method. We learned early on that actually when we're doing our assessments, especially the first time that we meet people, it's much better to do that face to face. You get a much better understanding of what it is that people are experiencing and going through. However, with other groups, such as the IAPT service users, for example, we did a big survey with the people that use our primary mental health care services for IAP, who actually indicated to us that they much prefer digital methods. They find it easier because they don't have to travel, they don't have to park their cars, they don't have to leave their homes in some circumstances. And so for that group, that's a particularly helpful way of delivering. And in fact, our IAP services were very early uptakers of the digital methods of communication using Teams and WhatsApp and all sorts of computerized CBT therapy to reach out to people. And the research that's followed that more recently has verified that using digital means for therapy is as effective, if not slightly more effective, as face-to-face therapies. As Chris was saying, however, what we do know is that there are a number of people within our service user cohorts that are excluded digitally for various reasons. They might not have access to technology, or they might find it difficult to find a safe space within their house to discuss some of the concerns that they have, or that they might have experiences as a symptom of their illness. We were talking about psychosis earlier, that make it difficult for people to use the telephone or retain the information. So we've responded, we've reassessed our service users' contact methods continually through this period in order to make sure that we get the right contact method for that individual. Some of that's around choice, and some of that is actually using our experience as mental health practitioners to make choices for people around what the most appropriate contact methods were. The second part of your question that you were asking was around has it affected the wait times or our ability to respond to people? Certainly within our IAPT cohort, it has, and using digital technologies meant that we've been able to get people into therapy faster, much faster, less wait times for treatment for people. IAPT was a particularly good service to adapt to. It's always done telephone assessments, and it just had to pick up its treatment through digital means, and it reduced the wait times there. There are other elective services, such as secondary care psychological therapy, where it's people have made choices around how they want to be contacted that's led to a delay in wait times for some individuals. And that's not because there weren't digital therapies offered, that's because people have elected to wait for face-to-face therapy because they feel that it's more appropriate to do that. In terms of the key performance indicators around wait times for our for starting treatment, there's been no change really in either direction around people being able to access our services. Like I say, there's been some improvements in some areas, especially around IAPT, and some slowdown in some of the elective services, such as psychological therapies, where people have elected to wait for face-to-face therapy.
Thank you. That's very helpful.
Thank you.
Thank you. Just on that, can I ask that do you have a date in mind for when face-to-face meetings are going to resume? I'm sure that you'll have done an assessment on these individuals that have been waiting, and you know, how long are they able to wait before they get a face-to-face meeting?
Absolutely. Those people, we have started a restoration and recovery, and where people are digitally excluded and have and are unable to use the digital technologies that are offered, then we're seeing people face to face right now. There's all those services, and as my colleagues were alluding to before, anybody that has a level of risk is absolutely seen face to face, and for our crisis and many of our services, we never stop seeing people face to face.
Okay, thank you for that. Lynn, I'll bring you in.
Thank you, Chair. I'm really pleased that both Melissa and Sue are present alongside yourself, Chris, because I think it's useful that you're all available to comment on some of the points that I would like to raise, please. And looking at page 3 of your presentation, which is our page 19 in our pack of documents relating to early response, the statement continued to provide assessment, care management and interventions using telephone and ensuring face-to-face contacts when clinically required. And I want to raise an example that's come to my notice, whereby a service user on the Kirklees enhanced pathway who has a long-term complex and potentially unstable mental health diagnosis has not been seen face-to-face by her care coordinator since the middle of March this year, with contact between them taking place exclusively by telephone since then, and this continues to be currently the case. Now, prior to the commencement of the COVID-19 pandemic, the service user in question was visited weekly at her home by the care coordinator, and the visits lasted for up to an hour. The telephone contact since March has stated to have been consistently far shorter in time length, around 20 to 30 minutes. And when asked about video calls by the service user, the care coordinator stated that video calls are not currently an option for contact between them. The service user would be able to participate in a video call because she has undertaken them with her GP during the pandemic period, and the GP talked her through the practical steps to enable this to happen. Now, this service user is in the clinically extremely vulnerable category when it comes to shielding from the virus, and so clinic appointments have not been advisable in recent times. To be fair, there have been several other South West Yorkshire Partnership NHS Foundation Trust colleagues who have visited the service user at home during the pandemic period, but this has been solely with regards to tests relating to the monitoring of medication side effects. I have made previous reference to my significant concerns regarding it not being points of engagement, creating the potential for key warning signs that would highlight a gradual deterioration in mental health being missed at an early stage. I do appreciate that a rapid deterioration is more likely to be obvious even over the telephone. And even video calls have limited capacity as regards picking up on some of those key early warning signs. Service users are assigned to the enhanced pathway for a reason, and so in terms of the red, amber and green system that's referred to within the presentation, personally I wouldn't expect an enhanced pathway service user to be allocated to the green category. And so I've viewed the graph relating to the core and enhanced team contact methods for the period from the 6th of January to the 6th of October this year inclusive, that's included within today's presentation documents on page 10 and the panel's page 26. I fully appreciate the need for care to be delivered in a person-centred way and reflect, as far as possible, the needs and wishes of an individual service user. But it is important to support and motivate service users to make choices that are in their personal best interests and that will underpin the principle of keeping them safe and well. Risk assessing telephone-only contact with an enhanced pathway service user for a period of 9 months flags up significant unacceptable levels of risk from my perspective. And it's the bigger picture that concerns me too, as regards whether the scenario that I have outlined is reflective of a similar practice being adopted with other enhanced pathway service users too. Just a comment, this isn't a criticism, by the way. It's not possible to identify from the contact method graph as regards whether the indicated face-to-face contacts consistently relate to just a few service users, and nor does the graph indicate where the face-to-face contact took place, whether in clinic or in a service user's home. And so even when a care coordinator is vulnerable themselves from a COVID-19 virus point of view and is therefore unable to carry out a home visit personally, other alternatives could be considered, such as a colleague carrying out the home visit and the care coordinator linking in remotely to a conference or video call and taking the lead in the conversation, which would be reassuring and best practice from a service user's point of view. And so this is just my personal thought, really, that the with hindsight learning that I've taken from this scenario is that there needed to be a protocol in place which imposed a without exception requirement for service users on the enhanced pathway to be seen face-to-face by their care coordinator, either in clinic or preferably at home, because I feel a home visit forms an important part of the risk assessment process too, and that to take place at intervals not exceeding a specified number of weeks. And, you know, whilst I'd like to think it could be 2 weeks, I think I'd reluctantly accept 4, with preferably a video call taking place on the weeks in between, if that were possible, and telephone contact being the last resort, as opposed to becoming the default setting. And so I suppose a little further point that I'd just like to raise as well is, bearing in mind we've been given quite a bit of information about an increase in staff absences, I'd like to know what should be happening as regards forthcoming appointments and actions required with regard to individual service users when their enhanced pathway care coordinator has a sickness absence, particularly when it extends beyond a few days. I suppose what I'm looking for really is what is the contingency plan that is deployed in those circumstances. And I'm sorry that that's taken me a while to articulate, but I felt it was important really to, you know, to cover all the aspects as I see them. Thank you.
Thank you, Lynn. Is it okay, Chair, if I just introduce something and then ask Sue to speak to that? If I can just make a few points to start us off. Thanks, Lynn. And obviously there's a lot of powerful information there, and it's difficult for us to, you know, you don't expect me to say this, comment on individual cases without having had the benefit of understanding that person's particular circumstances. One thing I did pick up was that you mentioned that the person had been seen by other members of the team other than the coordinator. And I think it's important to emphasise that the enhanced pathway is an MDT, multidisciplinary team response. And during the period that you've been talking about as well, we noted that the service user was clinically extremely vulnerable. We have gone through 2 episodes of lockdown, in particular the first prolonged, very strict lockdown. And I think we do have to always balance risk against benefit. And in the first part of the dealing with the pandemic, certainly, you know, from March to June, we were actually charged with minimising risk to the public and to our staff, obviously, and to members of the public and our patients of transmission of disease. So it's a very difficult balance to strike. I think I would say that I was reassured to hear that the person had their medication monitored, and I'd just like to add there that if somebody is on ongoing medication in the way that I think I understand from the description, every contact contains a risk assessment, and that is not just of the potential side effects or administration of that medication. It is about their mood, it's about their presentation, it's about their risk. So that would have been an ongoing process. I think it is fair to say that we did and we are having to rationalise how we are able to work with people, because we are dealing with great challenges in the community. And I think we have been able to maintain all our services. Some organisations, for example, haven't been able to do that, and they've condensed some of their offer, for example, by moving community staff into inpatient areas. I think we've not had to do that throughout our dealing with the pandemic, and we've maintained our services in each pathway. But I think the description that you give there, Lynn, of the enhanced pathway, we do have a lot of service users on the enhanced pathway, and they do have a range of needs, and we do work to a protocol in terms of risk assessment and how we're able to meet their needs according to their care plan. But I would be frank, it would be only those people at the very highest level of need and risk who will be receiving the services in the way that you've described in terms of face-to-face during this period. But I do want to emphasise that at no point has face-to-face contact ceased with people who absolutely need it. And indeed, the example that you've just given demonstrates that the person has had their medication administered and reviewed and their risk assessment taken in that way. We do have team responses in the way that you've described about contingency planning for staff absence. We've got a level enough of staff absence at the moment. We've had a fluctuating pattern, but we wouldn't allow service user need to be jeopardised by that, and we would always remobilise resources to those most in need. And indeed, coordinators have to do that as well. So we would take that on a daily basis, for example. We would always prioritise our resources based on a whole team caseload as well. So during this time, we've had to be doing that. So that can impact on individual care plans, because we do have to take, as I say, the most urgent and the most severe presentations at the top of the priority. I would ask Sue, who's obviously much closer to the services than I am, if she can add anything there. If I've started to explain, Lynn, what you've raised, if that's okay, Chair.
Yeah, that's fine.
Yeah, thank you, Sue.
Yeah. Chris, thank you. A lot of the points that I was going to make, you've already made, so thanks for that. I suppose, Lynn, just to, I mean, obviously you've talked in great detail about an individual's particular circumstances. I suppose just to widen the context of this with regards to face-to-face contacts, the other factor that we've had to try and manoeuvre and manage, as have all other primary and secondary care providers, is that of how we use our buildings, because home visits are only one method of having contact with people. Understandably, Lynn, in the case of the person that you're making reference to, they received their contacts via a home visit, but there's a significant number of people who prior to COVID received their interventions via a clinic-based appointment, by coming into, say, Folly Hall, for example. So that the other limiting factor that we've had to try and manage to protect the public, our service users and staff, is to carry out a building's risk assessment, which has very clearly reduced the capacity that can hold at any one time for face-to-face contacts. And I know that that's not that dissimilar to the way that the primary care practices have worked. For example, they've closed down certain practices and opened up others for face-to-face contacts. So again, that has to be factored in. So people who ordinarily would have had a face-to-face contact in a clinic-based provision, to try and work to the reduced number of people that our buildings will safely allow, we have had to work out different ways of carrying out those interventions. So it was just to add, I suppose, another challenge, and they are all challenges. And I think that the challenges that mental health services are encountering are no different to the challenges that other secondary care pathways, cardiology, oncology, etc., all of those have encountered. And so we've had to, obviously, as Chris has decided, we've had to first of all determine need and be really clear about how, the type of contacts that we need to make with people to ensure that their needs can be met safely. But we've also got to work with a number of different restricting factors as well. So it's been challenging. But I think, as we've said at the beginning of the presentation, we have managed to keep all aspects of our services going, albeit with a slight, if not significant, changes in the methodology of doing that. Sorry, Lynn, is there anything specific? I know Chris has covered quite a lot, and we can't comment on individual cases, as Chris has said. But is there anything in particular that I haven't touched upon?
Well, I think a comment has been made to me by a member of staff, and this isn't me trying to get people into trouble, because, as I've said many times before, I see us all, in whatever capacity we come to these meetings and other community forums, as being part of one big community team, working together for the good of our community members. But with regard to the video call option, which I noticed from the graph about the enhanced team contacts is basically flat along the bottom, what I've been told is that staff on at least some of the enhanced pathway teams in Kirklees don't have the option to make video calls. And I was wondering whether a digital audit had been carried out about what is actually available and whether it could be made available via the various IT teams, but also a skills audit for staff, and is there a training need? And if we can't do example video calls, there is the option to do a conference call, which might be able to involve a relative, next of kin who was at a distance location, but they could feel involved in those telephone conversations. And the good thing about involving them in that way, obviously with consent from the service user concerned, is that afterwards, if the service user's, you know, struggling to recall everything that was said, conversation, often the third party, the relative or next of kin, or even a friend with consent, would be able to remind them of what had been said.
Yeah, thanks, Lee. And just a few comments. I mean, you're exactly right. Originally there was technology issues, so we very quickly, during the very early part of COVID, did an audit of what equipment staff had and what equipment we would need to add to their toolkit, so to speak, to enable them to work in the way that we were being asked to work. So we very quickly managed to sort of mobilise quite a lot of new equipment out to workers, and you know, so that was a challenge. And you're right, there will still be members of staff now that don't have the absolute full set of technology available to them. It's appraisal season at the moment, and a lot of those needs will be picked up in appraisal. So we continue to work on that, but it's a significantly improved picture from when we first entered the COVID period in wave one. The second thing is around skills. Again, you're right. There has had to be some very quick learning around using IT-based systems. Some of the IT that we'd got wasn't appropriate to use with service users, so we've explored the use of new platforms from an IG point of view to make that safe, because we do have to consider when we're using digital forums that it is a safe way of doing it. So staff skills are becoming much broader with regards to the use of equipment. So there were two significant challenges that we probably haven't got to an end point. But we certainly made significant ground quite quickly, really early on, to make sure that more staff had access to the technology that they would need.
Thank you for that very comprehensive reply. Can I bring Councillor Hanson-Munro in? Hanson?
Hello, thank you. This question's slightly shorter, so thank you very much for your explanation there for Lynn. I just wanted to, it's in relation to IAPT. I understand the current waiting time is 8 weeks to receive support. In the interim, I think a crisis telephone number is given out. And while I've heard that some people are very happy with your service, I've spoken with others, or other people have contacted me and said that they didn't think it was that having to wait all that time was helpful, and I think they still felt that they needed more support. So I wonder if you could tell me basically how you think it's working. Has there been greater take up during COVID? What's the usual waiting time for support in a normal period of the year? How do you know your telephone support is successful? What are you measuring that? How are you measuring your impact? Just wondered if you could provide me with any information, please.
Hello, it's Melissa. I'll happily talk to you about IAPT. The wait to assessment, so that's the time at which that somebody would call up the IAPT service and say, I'd like some help and support, please. Normally, between that and the first contact with the individual is anywhere between 48 to 72 hours. So it's 2 to 3 days before we first get back to somebody. From that assessment appointment, clinical decisions will be made around what parts of the IAPT service is clinically appropriate for that individual. So it might be an individual one-to-one treatment, it might be counselling, it might be CBT, it might be a group, it might be a computerised CBT response, or it might be some self-help. Each of those different, what we call modalities or therapies, have different wait times attached to it. As you say, at the moment, our wait time for a one-to-one treatment can be anywhere up to 3 months, so 12 weeks. And the prescribed times for wait time, so what we're actually asked to keep people within for a wait time for IAPT, 8 weeks is well within that time frame. What we, and the beauty of the IAPT service is that it is absolutely based on research, and what the research tells us is that there is it's a good idea to have a little bit of wait between the assessment and the start of the treatment for people, for when they have their assessment, to start contemplating and thinking about how they're going to formulate their problems and how they're going to start and respond to treatment. Everybody going into the IAPT service is evaluated as having a low risk. So we're not leaving anybody waiting for that time period who would need an immediate risk response. They should be able to what we call tolerate or wait for a treatment for between 8 and 12 weeks. As you say, we do leave people not only with telephone numbers, but we also leave them with a pack of what we call guided self-help. So that is around strategies to help you manage your own mental health between that time. So it makes suggestions around how, if you were feeling anxious or stressed or low, you might be able to help yourself within that, with those circumstances to manage. What we do know is that if somebody between that period starts to feel that their mental health is deteriorating, or they're not able to wait, we provide them with telephone numbers to contact our secondary care service, well IAPT to start with, and then the secondary care services to manage any immediate risk that might come out of that. You asked about how do we know that works as a support mechanism. I guess the answer is that for the majority of people, and for IAPT services, we are looking at in Kirklees well over 600 people a month using our IAPT services, and what we know is that for the majority, that's okay. They can tolerate that. Is
that now? Sorry, is that during COVID, or is that in a normal year?
That's in a normal year.
Yeah.
So what we know is that there'll be a small amount of those people for whom actually they can't wait, and they do not, their mental health deteriorates across that period. And we do know that they do make contact with our secondary care services and into SPA. The other question that you asked about is how has the service been affected through the COVID period? Mm-hmm. In contrast to our experience with secondary care, where we've had increased referrals, IAPT has had a decreased referral amount. Now, we think that speaking to GPs and speaking to our service users and people who access that, we think that might have to do with barriers to accessing primary care. A lot of our referrals come through what we call GP-directed self-referrals, which is a very long way around saying that somebody's gone to the GP and the GP said, IAPT is the service that you need, here's their number and get hold of them.
I see what you're saying. Yeah.
And also we think that people who actually, the process by which you contact primary care might put people off with primary mental health care needs. If you're filling in an online form, it's one thing to fill in an online form about a headache or a rash. It's quite another thing to fill in an online form about the mental health problems. So we're doing lots of active promotion within our GP networks and in partnership with the CCG to get the message out to people that IAPT is very much open. We are very much wanting to help people with mild to moderate mental health problems and doing as much as we can to promote the service, that get the message out that the service is absolutely operating and that we want to help right now.
Oh, great! Thank you very much for that. That's really informative, and you know, obviously you've told us that you are hoping to catch all the people who you may have been missing. So because of the situation with COVID, so that's really helpful to know that. Thank you.
Thank you.
Thank you, Melissa. Leslie, are you back online?
For the moment, I'm really sorry about this. It's just I go for days and it's okay, and then important meetings. Anyway, I'm back again for the moment. Yeah, I think very much following on several things people have raised, and in particular, Councillor Munro. Clearly, the word challenge is used over and over again, and mental health has generally been the poorer cousin, although a certain amount of funding has come this way in the last year or so. But I'm very much aware that there's certainly at the younger end, there's many people not being touched. CAMS can't cope with the numbers and the waiting lists for help. And I'm just wondering, with the combination of your own staff, illness and shielding, and the fact that you yourself have just indicated, which I thought would be the case, that it's very difficult to get to see a doctor. Some people, even though they know they're not right and they're really worried about their mental health, are also more worried about seeing a doctor and possibly, going into the hospital system. So my question really is, is there the possibility that there's quite a large number of people with serious mental health who are not yet being able to be in contact with anybody? And the second question I wanted to ask was what use the service makes of volunteers to try and support people, particularly those like Lynn was describing, who are feeling very isolated. They aren't seeing their regular person as often. They don't want to do it on Zoom, or they can't, and they need that personal contact. So, community groups are doing quite a bit at supporting with the practical things, but I just wondered if you worked with groups of volunteers to train as, a helpful listening ear, etc.
Thank you, Leslie. In terms of the potentially undiagnosed people in need of services that are there and we don't know about, I suppose that's a very difficult thing to answer, isn't it? Because I suppose it's something that we wouldn't really know about, so we couldn't comment on the extent. I think the indication is that during this period, there've been more available access points for mental health services. In fact, at Bradford, Leeds, Wakefield and Barnsley and Kirklees and Calderdale, there's been a support line opened up at ICS level, which has been accessible, I think, 24 hours a day, and that's had people contact it. We have our own services available, and there is a contact point, albeit through home-based treatment overnight, and we do have a high number of self-referrals as well. We've no reason to think that those barriers are insurmountable, but undoubtedly the experience of COVID has led some people to find it very difficult to access services and frightened to do so as well. And I do take the point, Leslie, that people are worried about what mental health services are per se. And I think that destigmatisation, we might think we've got over that, and it's obviously the media and all the ways that people talk about their experiences nowadays. There's still can be very difficult for people to raise issues, can't it, in the way that Melissa's described as well. So I think the untapped demand is something that we are worried about, and we have considered in terms of our future planning. And again, that work's being done at a national and a regional level. in terms of the use of volunteers, I think we're very involved with the community and voluntary sector across each system. And I think the Recovery College work that we've presented on in the slides gives a good indication of that. And we do have befriending systems as well, and live well systems through the council and other providers. And I think Melissa might have some more information in terms of how the IAP system links in with those as well. We do have a trust-wide volunteer programme, which is very well governed and does some excellent work with service users throughout our pathways. So I don't know if Melissa's got anything that she could usefully add there.
Thanks, Chris. I guess our main use of volunteers in the pathways is through the Recovery College, which is absolutely volunteer led and has a real commitment to peer support working and volunteer led working, and also within our IAPT services, who help us deliver our group work and help us with peer support and peer support workers as well. We haven't fully tapped the potential, I think it's fair to say, of volunteers within our core secondary mental health service mental health pathways, but we have started along the journey of ensuring that we hear service users' voices in as part of our feedback in order to shape our services moving forward.
Thank you. Can I bring Councillor Liz Maging? Liz, do you want to ask a question?
Yes, thank you. I just wanted to ask about the SPA actually, because previously we've heard that if somebody isn't able to process through the single point of access, they can be referred to community organisations. And I just wondered how that had been happening during these past months, whether that had been in place or whether more people were fitting the criteria to go through SPA. And also you mentioned CAMS. Now, the delays in CAMS, etc. What about the adult CAMS? Has delays been created in that system? Thank you.
Thank you. I think we can ask Melissa and Sue to talk about SPA. In terms of CAMS weights, we have seen some significant improvements, I think, across the system. In terms of the adult CAMS, do you mean, Liz, the transfer of people from the CAMS system into adult services, the transitions?
Yeah, you have a adult CAMS service, or you did anyway. Have an adult CAMS service as well as one for children and teenagers. And we previously heard that the adult service was okay, whereas the other the children's one was really struggling. So how is that those services coping? Yeah,
I think the CAMS service per se has improved its performance in terms of seeing people and treating people, young people and children. There has been some acknowledged improvement, I think, across the system with that. For the community services for adults, which people move into, I think, again, we've seen that we've achieved our performance requirements in terms of weights and access. But that's something that Sue and Melissa could talk more about if that was useful. And then in terms of SPA, I don't know whether Sue or Melissa, have you got anything that you could contribute there from the local meetings that you've attended? We haven't got Gary with us today, who leads on SPA, but our systems are all connected, aren't they?
They are, Chris. Yes, sorry, it's Sue back again. One of the things that we have noticed, and we have raised this with commissioners, is that some of the you explained that if someone's referred to SPA and the assessment is that person doesn't need to come into secondary care services, that we would try and link them with an appropriate community-based support, often delivered by the third sector. One of the things that did happen, particularly early on in the COVID period, was that some of the third sector stopped doing group work, for example, because they encountered some of the very similar issues that we'd encountered. The buildings weren't appropriate to house group work. The people were reluctant to come out and come into a group work environment. So we to be fair, we did experience some difficulty in that onward referral. I'm pleased to say, probably in line with everybody from a service delivery point of view, that the third sector has equally gone through the restoration process as we have, and they are now finding a balance between platform-based groups and actual face-to-face contacts as well. So I think there was probably a bit of a lag in them doing that, but that was certainly something that we noticed, and service users who use those services, as well as secondary care services, who were supported by third sector community groups, were feeling the loss of that direct face-to-face support. But it has, as I say, it has been restored more now. So so SPA did that did have an impact on SPA and the resources that were available to them.
Thank you for that, Peter. Are you wanting to come back in?
Yeah. Thank you, Chair. Yeah, I mean, just really a follow-up. We've asked an awful lot of you about delay and people having to wait, and we know that because you assess people properly, that some people you've assessed that they can afford to wait. I thought I'd been reassured about this at the beginning, and I'm sure I probably have, and I take all the arguments about destigmatizing, but there is a sliver of the population here who are mentally ill. They are mentally ill. They experience psychosis of a sort that disorders their thoughts, it disorders their ideas, it enables them to hear things that are not there. They are deluded and they're insightless. There are similarly people who are manic. There are similar people who are morbidly depressed, pathologically so. How are we to be reassured, please, that these acute psychotic people will be seen? There's no point in leaving them a user pack or a set of telephone numbers. How will these people be seen?
Peter, thank you, if I may, Chair. I think one of the things Melissa said when we were describing what we've been doing is that we've made a key priority about seeing people for assessment. And I think that's been a big plank of how we've been able to keep people safe and maintain the priority of our service during this period, in that we recognise that it's very difficult to undertake an assessment on somebody that we don't know without actually seeing them and without understanding what their environment might be like, etc. So increasingly, obviously, we have just had a period of extra national restrictions, but it didn't change our recovery pathway, and we're doing more and more work in the community with people as we were before, and as Sue has explained, using our buildings to see them safely as well. For example, we're running full memory clinics for people with suspected dementia from Folly Hall and Laura Mitchell in Halifax, and indeed throughout the Trust. And we're seeing people for first assessment appointments as well at those centres, but also in Dewsbury, and also in their own homes. So I think, Peter, we'd have to say that each referral we get is very carefully risk assessed in terms of what the indications of that person's distress or level of need might be, and then a decision taken about what is safe to do in relation to that assessment. And I would emphasise, and I think this is really important, our crisis and home-based treatment service, which operates 24 hours a day, 7 days a week, has never stopped seeing everybody that it has referred to it who meets the criteria for an assessment face-to-face. We haven't attempted to do those assessments in any other way than we always have, and that's been a constant throughout this period. And indeed, our inpatient wards, as I'm sat here now at Fieldhead, are full, and people are coming into those wards as they need to. And obviously at home as soon as they're able to as well. So it's very difficult to say absolutely for everything 100%, isn't it? But I think we can. I've certainly got a very high level of confidence about how we are working with people to keep them safe in the community and enabling them to access services when they need to, and understanding their needs when they are assessed by us as well.
No, that's fine. I mean, you're dealing with a very unpredictable population, and and I'm sure you know from what you've said that's most reassuring. Thank you.
Thank you.
Thank you, Chris and Peter. Lynn, were you wanting to come back in, Lynn?
Yes, thank you, Chair. Just to say thank you first of all to Chris, Sue and Melissa for their comprehensive responses to my earlier questions. And in the interests of getting a balance, I always like to give credit where it's due in this forum as well. And so with regard to the Kirklees and Calderdale Recovery and Wellbeing College, and the word wellbeing has now been incorporated because it's felt, I believe, that this helps to highlight that a person can use the college in order to improve and sustain mental health and emotional well-being as a form of early intervention and prevention, in addition to the colleges supporting people who have experienced significant mental ill health. And so I just want to echo the feedback comments on page 12 of the presentation, which is the panel's page 28, regarding the Recovery and Wellbeing College support, because it makes a massive positive difference to the lives of the people who engage with the college. And of course, there are other recovery colleges in both the Barnsley and the Wakefield areas that come under West Yorkshire Partnership, NHS Foundation Trust. And there are online courses and online meetings taking place on a regular basis, and getting feedback from service users and fellow volunteers that is very much appreciated. And also just to point out the innovative strategies that South West Yorkshire Partnership Foundation Trust has in terms of the work with the Kirklees Library Service that the Kirklees Insight team undertakes. And it was mentioned earlier that team provides early interventions in psychosis for people in the younger age group. And just quickly moving on, page 13 of the presentation, which is the panel's page 29. This is a really positive and effective support tool for carers, the Carer Passport. And so I was wondering whether the launch event or the passport, which took place online on Carers' Rights Day on the 26th of November this year, whether it could be made available as a podcast for our panel members to view so that they can perhaps get an insight into it. And failing that, maybe some documentary information that would help to illustrate really the very wide and positive scope of it. And my final word, I promise, this afternoon on this presentation relates to page 5, which is the panel's page 21, where there's reference to the Grief and Loss Service. And I just wanted to highlight that is the West Yorkshire and Harrogate Grief and Loss Service, which is delivered by the West Yorkshire Partnership. And I think it's important to highlight that this service encompasses loss in a wider context than just in relation to bereavement. And a few examples are loss of a relationship, loss of a job, feeling surrounded by grief and loss in the workplace, loss of identity or role within a family unit, potential loss or fear of loss in the future, and even loss of a pet, which can have a profoundly negative impact, particularly on someone who might live alone. And that's not an exhaustive list. And this is a free service It's available from 8 AM to 8 PM, 7 days a week, and it includes telephone, text, and online chat options, and it also provides translation facilities. So hence it's particularly relevant that we all promote it at the present time. Thank you very much.
Thank you, Lynn. Thank you for that. I'll take away the issue about the podcast. I'm not sure that that is available, but I will check with Abu and colleagues, and failing that, anything else that we might have from the day. But thank you. Thanks.
Okay, well, thank you for that. If we can just move on to the recommendations for this report. If we can acknowledge the report and the information that has been presented to us this afternoon, we consider that. One thing that I would like to request is if at some point you could give us the impact and implications of the pandemic, what implications that you've had on the mental health services in Kirklees, and maybe some key lessons that have been learned, and highlighting some of the key issues that may have faced the service through the pandemic. I'd like to thank you for attending this afternoon, and that you've worked extremely hard on mental health services, particularly throughout the pandemic. So on behalf of the panel members, I'd like to thank you. You're welcome to leave the meeting. We're now going to move on to the next item.
Thank you, Chair.
Thank you.
If I may, I will clarify with the clerk the precise requirements for the next item that you want from us in terms of the impact. I'll come back on that if that's okay. Thank you very much. Thank you, everybody. We've all got clinical work to undertake, so thank you for having us today, and for all your questions and engagement. So we'll say goodbye if that's okay. Thank you.
Thank you. Bye.
Okay, if we could move on to the next item, which is COVID-19 update. Jane.
It's me first, Councillor Zama, and then Jane's going to do a bit, and then I'm going to do a bit. So we're going to do it between us, if that's okay. I hope that you can hear me. I hope my internet connection survives the next half an hour. The Sky engineer is on his way because it's not been right all day. So bear with me if the connection isn't brilliant. We'll do our best. So Jane needs to leave at 3:30. So if you don't mind, Chair, we're going to swap around a little bit the order in which we were going to do things. So Jane will give her update first on the vaccine and the testing situation, and then I will come in and do the data piece towards the end. And I'm going to give you a verbal update on the data rather than using the slides that were previously submitted, because the data position, as we thought it might when we last met, the data position has changed quite significantly since those slides were submitted, because of the requirement to submit them in advance. So if you're in agreement with that, Chair, that's what Jane and I would like to do.
Okay, thank you for that, Emily.
Okay, so I'm going to hand over. Sorry.
Keep it as brief as possible and allow panel members to ask as many questions as possible.
Yeah, absolutely. Jane's going to talk quick, then I'm going to talk quick, then we're going to answer your questions.
Okay.
Okay, yeah. Jane, over to you.
So as regards testing, obviously I think you've seen the slide pack. One thing to mention additionally in with regard to testing now is that services for extra care and supported living now, staff and residents now have access to testing. That started as yesterday, following the pilot rollout. So staff will be tested weekly, as in care home settings, with residents tested on a weekly basis. This includes also ancillary staff within these settings. We obviously submitted our facilities within Kirklees for the national pilot, and so all our sites are actually engaged with this. We've done a lot of work with extra care facilities throughout the pandemic as well, and done a lot of support from the IPC team because we have seen a number of small outbreaks within these facilities. So that is a positive to note, that testing is now available to these individuals. we're successful. We put in a proposal for the targeted testing. So we've now received those swabs. That is where we're looking to actually test people who are in contact with vulnerable. So if we look for instance, people who work with drug and alcohol, people within drug and alcohol services, individuals within residential children's care home setting, children's social work, adult social work settings, and also looking at staff within special schools, high risk workplaces as well. So we're starting to engage with these services to say, would they be willing to be part of targeted testing? It's what we call a lateral flow test. So it's where they actually do a self swab. And then if that's positive, that goes then on to have to have a confirmatory PCR. So either at a walk-up site or at a local testing centre. That then links into, if somebody is positive, that then links into test and trace, and obviously receive the support from that. And obviously you have seen that we'd obviously put a submission in as well for wider community testing as well. So those are really the regards the testing. The only other thing to mention is, as part of my proposal, I did put in about obviously care home visitors, but that was superseded by the national rollout of the Department of Health and Social Care doing direct access to care homes for their visitors and friends to access testing. Would you like me to take questions on that first? Because I've noticed a couple of hands raised.
Yeah, you can do. I'm also conscious of Emily's time as well, so we can keep your questions brief, please. Peter, do you want to go first? Peter, we can't hear you.
Is that better?
Yeah.
Thank you. Jane, apologies. If we could go to lateral flow testing, please. Given I just wondered how much reliance you're placing on it, given the reports about its sensitivity and its lack of specificity. It seems you've got to be absolutely laden with this virus to be really sure that you actually need a PCR. And that otherwise, you might be turned away, and that if you've been tested by a non-professional, it gets worse. It gets down to 50%. So, and that's Porton down. That's not me. These the evaluation. What we've got to see it as is it's part of control measures. It's not the panacea, should we say, for people to go and see their loved ones without wearing personal protective equipment in a care home. It's part of those control measures to identify individuals with a high viral load at an early stage before they become symptomatic. Because what we do find with people with the lateral flow test is a number of days down the line, they tend to start with symptoms of COVID. So no test is 100% accurate. No, the PCR isn't. So it has to be seen as part of a suite of control measures to try and identify people with high viral load. Great, you've put it in perspective. Thank you very much. Thank you.
Thank you. Dave, do you want to ask your question?
Yes, thank you. It's on the care home testing update and the discharge of people from hospital. So the report says that some residents may have received a positive COVID-19 test but be ready for discharge from hospital. First question is, what are the criteria for deciding whether that is appropriate to discharge or not? And secondly, it refers to the step-down care homes. And I know those have only very recently been set up, but how is that operating and what kind of problems have they faced? Thank you.
What we find with individuals, if they're medically fit to discharge and they've had a positive PCR test in hospital, the IPC team tend to, if they've come before from a care home and that care home is willing to receive them back and can meet those needs, then that individual will complete their isolation within that care home. And we found that quite a lot of care homes are more than willing to take those residents back. Obviously, we've got some care homes where they would prefer not to receive back. So this is why we have started looking at the designated care home beds to receive patients that are PCR positive, so COVID positive. As regards how they're running, I can't really answer that. My team have what they've done is they've gone and done the IPC assessment for the designation, because obviously these care homes have to be signed off by CQC. So we've done a lot of partnership working with CQC on those, and ones what have been identified, the team members have gone in and given their report on suitability.
So is that a very different situation from the one during the first wave of the pandemic?
Yeah, it was. This is different. Yes, so they will take what we call REC patients, so positive. They could have an upstairs floor which was full of positive COVID patients. Yes.
Okay, thank you.
Councillor Alison Munro, do you want to ask your question to Jane?
Thank you. My question is really linked to Dave Rigby's question. It's on page 40 in relation to the step-down care homes. How many of them are there across Kirklees, and how many residents with COVID can they each take? I'd also like to know, are you saying that some care homes are willing to take patients who are being discharged from hospital with COVID, but how can we be assured that they can adequately, save that person's life if they start to deteriorate? And are their staff prepared to deal with them, and have they got insurance to deal with them? If you could answer those questions, please.
Right. Some of the questions, what you've answered there, I would have to go away, because obviously that is part of adult social care. It doesn't fall to health protection. But right. There's definitely an escalation process where individuals, if they start to deteriorate, obviously care homes have obviously access to their GP, and they actually have access to what we call it's the cohort team. So it's a support team which is provided by Locala, what goes into care homes to support them with the residents. As regards indemnity, now I know that there's been a lot of discussions about indemnity, but there again, I can go back and find that out and bring that answer back to you, Councillor Munro.
All right, thank you. Can you just answer the bit? How many of these step-down care homes are there across Kirklees, and how many residents can each of with COVID-19 can each of them take?
There again, I will have to go, because this is obviously these have only just been reviewed, and whether they've been signed off by CQC, again, I would have to go and ask the question and come back to you on that one.
Right. Okay. Okay. Thank you very much.
Thank you.
Thank you.
Leslie, bring you in.
Yeah. I think Alison and I must be, Councillor Munro and I must be on the same wavelength, because again, more or less the same question, but just an addition to it is the way these step down care homes are chosen. It's sort of, I find quite interesting, because potentially, some of the people who work in care homes are not exactly the best paid. They can be in one or two care homes. And is it the management making the decision? People potentially with COVID coming from hospital to a care home, and management saying, yes, it's fine. But in reality, is it fine? And I mean, obviously, I know you're going to try and prioritise care home workers for vaccinations, but it would be quite interesting to know the criteria that a step-down care home is chosen, and that staff are fully aware of it, and not just the owners or the managers, because I just see potential for risk and putting fairly low paid workers at risk, really.
Again, Councillor Warner, I will have to take that away, because it's an adult social care question, is that, but quite happily we'll feed that back to you next time.
Okay, thank you.
So if I go on to really just a little bit of an update how our local contact tracing is working. So we've had 1 full week now of rollout, and we've managed to actually contact 50% of the cases. These are cases what I've said previously would be hard to reach. So there's a number of cases which are actually hospital inpatients. So at the moment we're closing those off. I'm in dialogue with both CHFT and Mid Yorks to see whether we could put a process in place, but our concerns are we wouldn't want the local contact tracers to be ringing an individual who's in an inpatient because they obviously could be acutely unwell. That's the reason for them being in hospital. So we're looking at a process where we're not in breach of IG by obviously contacting families directly, so hopefully to try and increase that contact tracing. But our failures really have been due to the fact that we've had quite a high number of inpatients with COVID who the national team haven't managed to contact.
Thank you. Emily, are you wanting to come in now?
No, I'm sorry, Councillor Zamani. I got chucked out and then I came back in, so I was inadvertently attention seeking. But if Jane hasn't finished, she can keep going.
No, I'm just giving the update on local contact tracing and how that was working, Emily. So unless there's any questions on that, really.
Questions?
Yes, sorry, raise hand this time. Can I I'm unmuted. There's too many things to remember. Okay. Can I just ask if the designated sites have you designated all the sites for vaccinations? Are there still some more to be designated? Obviously, it's a fairly fast moving thing. Yeah. And the other thing was about training in the long run. This is a very ambitious program, and how you're going to get the people to do the vaccinations. Are they going to be medically trained people, or are lay people going to have to be trained in giving vaccinations?
Well, the COVID vaccine program is obviously an NHS-led program, which we're supporting from a local authority basis. I go on the meetings to give IPC support, health protection support. We've obviously supported with looking at potential sites, what they could use, which are our council buildings, and obviously we're looking at traffic management. But ultimately, the sites are chosen and have to be signed off by NHS England. This isn't a local authority decision about which sites are actually designated for use. So we are working in collaboration about the sites, and obviously the sites will potentially be based on PCNs. Is that not right, Emily?
Yeah, that's right, Jane. So yeah, they're likely to be sites where a number of GP practices in the form of primary care networks come together and deliver collaboratively, because I think it was Councillor Warner, it was your point, wasn't it? This is an ambitious programme of work with a lot of people to get through. So doing things at scale is going to be key to this.
Yeah. And as regards the administration, it will be people who are medically trained to give the vaccine. Workforce, GPs, district nurses. I've got a member of my team who's gone on the bank, and she's she's wanting to do it within her own time on a weekend. She's put herself forward, but obviously as part of this, we will need people who are non-clinical to help with registration, without marshalling, etc. So, there's a lot of individuals, clinical and non-clinical, involved with the delivery of this programme.
And is the funding there for it? She says, big question.
It comes from, yes, again, that is provided from NHS England for the delivery of the programme.
Thank you, Jane. David, can I bring you in?
Yeah, I just wanted to say it's very positive news about the new local tracing service. And just in terms of the problem you outlined about difficulty of tracing contacts who are inpatients in hospital, It would perhaps be useful if we could have some feedback on that before our next meeting, in terms of whether that problem gets resolved or not.
Yeah, thank you. Yeah.
Thanks.
Alison, did you have your hand up?
I did actually, but I'm not. It's just I just wondered if the need for volunteers, if they were being advertised locally. I know my son applied to be a volunteer to help with the vaccination programme over in Manchester, but I wondered if that was also happening here in Kirklees as well for the non-clinical side. You know, how is that being advertised in our area, if you know? Oh.
I think it will be advertised, and the opportunity for people to volunteer will be publicised through Kirklees. I think we're maybe a couple of days behind where Manchester are, so it's difficult to ask people to volunteer in advance of knowing where we'll be asking them to volunteer in, because that will inform their decisions. But certainly Steve Brennan is the SRO for this piece of work, and I know that volunteers and staffing more generally is on his on his radar. Probably quite a long list of things to do.
Yeah. Okay, thank you, Emily. Thanks.
Yeah. Emily, what's SRO?
Sorry, I'm sorry. That's my slap my wrists for using an acronym. Senior Responsible Officer.
Okay, thank you. Liz, are you?
Apologies. I think my husband thinks I just speak in acronyms.
Never mind. I just wondered if it would be worth the scrutiny panel hearing some information from Steve Brennan as to the rollout of the vaccination programme in Kirklees, whether that would be something that it could have updates from him on that. Yeah, because quite clearly Emily giving some very good information, but it's quite clearly an NHS-led programme. Yeah,
certainly is, Councillor Smage. It is NHS-led with our support.
Thank you. Councillor Warner, are you wanting to come back in?
Yeah, sorry. Yeah, it was just generally on the childhood immunisations. I'm just interested on the fact that you're redeploying staff, and my big question, of course, is from where? Because it seems to me that whichever aspect of the trust we're looking at and the work you're doing, you're all maximally challenged. So I just wondered how you redeploy staff. You just take them off the ward for the day,
As regards COVID vaccine?
No, this was just the childhood immunisations. I was just looking at that bit. Sorry, I'm ahead of myself a bit.
In childhood immunisations, in North Kirklees, there is a dedicated locala team, and they have continued throughout the pandemic to deliver the childhood vaccine programme. And obviously across North Kirklees, it's predominantly, it's a fully led GP, and that has continued throughout the pandemic. It was very clear from the onset that we must continue to prioritise the childhood immunisation programme. What we didn't want is another communicable disease increasing in, alongside COVID-19. So we will have probably seen a lower uptake because a lot of families have been hesitant about coming, even though extra control measures have been put in place to reassure. You will always have people who will say, I would prefer to wait and things are in a better place. But preliminarily, I think from talking to colleagues who have been involved with the childhood IMS programme, we've continued to, and from Q1 data, we've still remained very well, I would say, as an uptake for childhood IMS. We've always done very well in Kirklees.
Thank you. Lynn, you're wanting to ask a question?
Yes, thank you, Chair. I just want to ask whether there's any profile yet in terms of where the vaccination of domiciliary carers will sit in terms of priorities.
Jane, do you want to
I would expect that these would come in as part of social care staff, to be honest, because they are classed as, you know, they are home care, will come into a home care, Emily. That's my understanding.
Yeah, that's certainly my understanding,
Yeah.
and it's very much the position that we've been pushing for as a local authority, that we recognise domiciliary care workers as part of our social care workforce. So I would hope that they would be in that very early
rollout.
Okay, thank you.
Thank you for that.
Leslie, you wanted to come back in? Okay. Okay, well, thank you. If there's no further comments, if we can acknowledge the information that's been presented to us by Jane and Emily, and also COVID is a regular standing item on the agenda anyway, but if we can have feedback on the immunisation rollout programme next time, and maybe...
Councillor Zaman, do you want a whistle-stop tour of the data or not?
Oh, you could email it to us.
Okay. It's probably easier if I just send you a link to the public-facing dashboard, and you can look on there. Okay,
and then if there's any questions, you know, panel members can.
In fact, I'll pop a link in the chat, and then it doesn't clog up your inboxes. But yeah, I'll do that.
Yeah, Councillor Zeman, Councillor Rigby asked for an update on the inpatients prior to the next meeting. Would you want that information just sent to yourselves to circulate out to members?
If you send it to Richard, and then he can send it out to the panel members.
Right, thank you.
Yeah, but then, you know, for maybe the next meeting, if you give us an update on the
other questions. Yeah, thank you.
You just promoted me to a councillor. I'm actually a co-optee.
All right, sorry, apologies.
No problem.
But can I just ask, generally the numbers are beginning to go down a bit, is that correct? It is looking a little brighter.
So I tell you, I can do this really, really quickly because I've done it quite a lot. I'll just give you a real whistle-stop tour. Okay, so in the last week, we've had 75 hospital admissions, which is significantly down on the previous week. And we currently have 154 inpatients, 24% of whom are aged over 80. The cases are down 26% on the previous week. We've had 921. And that takes us to below the level from October. We're now 28th in the country. You'll have noted on the slides that we circulated in advance of the meeting that we were previously much higher than that. We were around 4th or 5th. And we're now lower than Calderdale and Bradford, but continue to be higher than Leeds and Wakefield in terms of the West Yorkshire picture. We have cases in all wards, although we continue to see a slightly greater concentration in North Kirklees, but that's not to say that there aren't significant numbers of cases across all of Kirklees. So it's generally looking like a much more positive picture. We're riding the crest of the wave of the impact of national lockdown 2.0. So it remains incredibly important that people remember the social distancing, the use of the face covering, washing of the hands, and don't become complacent. But we are starting to see that downward trajectory speed up a little bit, and we can only hope that actually as we move into tier 3 and into the period of some different restrictions being in place over the festive period, that we continue to see that downward trajectory. There you go. Said I'd be quick. Thank you.
What's your projection for the second week in February?
I'm not a betting woman, Peter, but I wouldn't put money on the numbers going in the right direction then, to be honest. I think I don't know if people will understand the cultural reference of Jurassic Park and the line in it where they said we were so busy wondering whether we could, we forgot to wonder whether we should. And my position on visiting people over the Christmas period is just because you can doesn't mean you should. And if people can, maintain that contact with their families, but do it in a way where you don't mix and you stay apart from other people, you absolutely should be doing, because it's that's working.
Yeah. Have a happy Christmas, Emily.
Yeah, absolutely. You too.
Panel.
Yeah, thank you.
And thank you both for attending, and I'm conscious of your time and appreciate all the hard work that yourselves and your teams have been putting into working around the COVID stuff, particularly, you know, because it's a pandemic that just sort of turned up, didn't it? So thank you for everything that you've done for us. You're welcome.
Thank you all.
Meeting.
Thank you.
Thank
And
you.
happy Christmas back to you as well,
Yes.
Peter. It's a bit soon, but
Stay safe and get a break.
thank you.
Thank you.
Okay.
Thank you. And if we can move on to the next item, which is the work programme. So in terms of the work programme, we, as you'll see, we don't have anything beyond February. And that is mainly because we're going to be discussing some of the items that we want on the agenda beyond that at our session in January. So in terms of the session in January, we're going to be looking at resetting of the NHS and care services, reevaluating the work programme, managing the agenda plan and maybe look at the approach, how the panel reviews and scrutinises issues in the future, particularly now that we're having meetings. So in terms of the February meetings, we already have the analysis of people's care home market COVID-19 update, which is a standard item, and CCG's merger, which currently is provisionally booked, but we're just waiting for confirmation on that. Comments on that? Peter, are you wanting to speak?
Apologies, dementia, forgot to take it down.
It's okay. All right, okay. Dave, are you wanting to speak?
Yes, I emailed Richard and he suggested I raise this at the meeting. It's just in the Francis report, which was circulated, there was a reference there to scrutiny panels getting information about the priorities of the Health and Wellbeing Board. And I just wondered whether, I mean, it may not be necessary to actually include that in a meeting. Maybe we could get that as a written document, just what key priorities the Health and Wellbeing Board are dealing with, and then we can digest that. And if there's anything arising from that, maybe we could bring it to a meeting in the future.
Okay, so if we can bring that information to the January meeting.
Yeah, that'd be great, thanks.
Okay. If there's no further comments, that brings us to the end of our agenda for this afternoon. I'd like to thank you all for your contribution this afternoon and also contribution so far in shaping the scrutiny agenda and also you know, in contributing towards meetings. If you haven't confirmed your choice of dates for the January workshop, if you could do that as soon as possible so that we can start planning and speaking to some of the contributors to that session.
Chair, can I just raise a couple of issues just for the notes? Councillor Smage raised an issue about Steve Brennan. I think he's the officer that's dealing, with the vaccines and various other things. Do you want me to have a conversation with Richard when he's back about potentially scheduling that into one of your meetings?
Well, if you share the notes with Richard, and then Richard and I usually speak, and
all right, okay,
we try and plan.
All right. And then I support the Health and Wellbeing Board, so I'll make sure you have a copy of what their priorities are, and I'll ask Richard and yourself to how best to deal with that. Yeah, that's fine. Yeah, thank you.
Thank you. Leslie, you wanted to comment?
Yeah, it was only just to come back on this thing that I do harp on a bit about, which is if at any point we're going to be able to have a few more meetings so that we don't feel that things are rushed. I know it's the thing about technical support, but at the council meeting the other week, I mean, Liz herself said we are one of the scrutiny meetings with one of the largest briefs, and I just want to feel, you know, she says coming in late, sorry, that we have enough time to really make sure, you know, we are looking at all the range of things that are happening. And the thing that, you know, I am concerned about is this ongoing increasing use of private hospitals and services and the cost that that is going to have long term to the NHS. I did ask a question about when the NHS refers people to the private sector, do they get discretionary rates or do they have to pay the usual rates? Because clearly, you know, one doesn't like to think about the bill at the end of all this. So I just want to make sure we have enough time to do this job as well as possible. That's all.
Okay, well, thank you for that, Leslie, but we have been trying to raise that, and obviously at this moment in time, it is due to capacity that we can't have more meetings, and also with it being virtual, it is extremely difficult. But it is on our radar, you know, we are aware of it, and we will try and address that. If there's no further comments, I'd like to close the meeting, and thank you all for your contribution to the meeting.
Thank you.
Thank you.
Yeah.
Thank you very much.
Happy Christmas, everybody.
Yes.
Happy Christmas.
Oh, yeah.
Thank you.
Yeah.
Bye.
I not think about that.
Okay.
Yeah,
Bye.
happy
Bye.
Christmas, everybody. Have season's
Bye.
greetings, everybody. Yeah.
Bye.